I am really thrilled to finish the month of April with one of our most popular guests. We've had several discussions with Dr. Drew Falconer, and he is just a wealth of knowledge in the Parkinson's and movement disorder area. And these neurodegenerative diseases are impacting so many people, especially older adults. So without further ado, because I feel like my foot is about to enter my mouth, let's welcome Dr. Falconer to the stage. And Dr. Falconer, great seeing you. I like to share with everybody that my good friend Sonia Gao who works for Dr. Falconer, is the person responsible for my world intersecting yours. And I remember when she's like, we got to have Dr. Falconer on one of your talks. And I was like, really? Is like Parkinson's and movement disorder, is that something that the general population of older adults really needs to know about? Oh, yeah, Steve. And I trust everything that Sonia says. And
As do I.
At first discussion, I'm sitting there listening, and it's the first time that I've heard any of this information. And I realized that my mom's hands had been shaking ever since I remember. And and I hear Dr. Falconer say, folks, if you've got this essential tremor, there's a lot of treatments for this. So going to the punchline, my mom and my cousin both met with Dr. Falconer, and they couldn't be happier, and their treatment is minimized. And I'll tell you what my mom, the thing that she said is that when the movement subsided, she had a tremendous amount of energy. And my gut level feeling is that folks with movement disorders, they may be, are they trying to sort of keep their hands steady or what have you? Like, they're probably devoting a lot of energy trying to mentally not shake their hands. And when they're treated properly, they've got all that energy that they can devote to productive things.
Oh, it's absolutely the case. If you have issues moving through space, if you have issues getting up and walking, if you have tremor or any sort of abnormal movement, that's all movement. That's all muscle activity. That all burns calories. That makes people tired. We see all the time where we'll have folks who are either undertreated or not treated for these conditions that we treat. We spend some time working together to get a good logical plan in place. The symptoms get better, and all of a sudden they say, holy cow, you gave us our life back, because now I don't need 3 naps a day. I can go out there and do what I want, though probably not today because it's disgusting outside.
At least here in the Mid-Atlantic. Yeah. So Dr. Falconer, I'm sure that we've got some of our regular folks that have heard you speak before, but I know that we've got some new folks that may be concerned about a loved one or concerned about themselves. So it's probably a good idea to just kind of like kick this off in terms of what is Parkinson's and movement disorders, and I'll let you roll.
Yeah, exactly. So this is Parkinson's Awareness Month. That's the month of April. Good time to hit that big question of what is it that we do every day. So in the world of neurology being the doctors who care for neurologic disorders. So you pick a part of the nervous system, be it the brain, the spine, the eyes, nerves, muscles, legs. A neurologist touches some part of that in terms of treatment and specialty. In our world of neurology, though, we have become a discipline, a subspecialty discipline that has subspecialists. So to simplify it, if you think about it, your cardiologist, your GI doctors, cancer docs, endocrinologists, all of those specialists are all internists, right? They did an internal medicine residency, they became internists, then they subspecialized in cardiology. Well, in neurology, we have the ability to become a neurologist through specialty training. And then through extra specialty training, you can become a specialist in MS, in headache, in epilepsy, in movement disorders. And so we think about ourselves as that further spoke on the specialty wheel, with general neurology being the generalist, right? And what we do specifically in the world of movement disorders is we take care of conditions that impact movement. I mean, I hate to be so simplistic, but it's true. We'll see anything, and we will tell you what you got, what to do about it. And if you need to see somebody else, we can help direct that. But what we've become real specialist in the movement world is the treatment of Parkinson's disease, essential tremor, shakiness, walking problems, that kind of thing. In fact, in our clinics, by number, probably 60 to 70% of the patients I see every year are Parkinson's patients, and that's true of most movement disorder specialists. So that's why our center, if you can see it, says the Parkinson's and Movement Disorder Center, because we really want to spell out to the world that the vast majority of what we do is specialty care for Parkinson's disease. But that's important because in the United States today, and you mentioned it, we have a huge burden of Parkinson's out there. There was a new study that came out 2 years ago from the Parkinson's Foundation that actually showed that we're probably grossly undercounting the amount of folks out there living with Parkinson's. Per that study, we are diagnosing today about 90,000 people every single year with Parkinson's. We're treating anywhere from 1.5 to 2 million people in the United States for Parkinson's disease. And for those folks that are over 65, you are not making it up that you're seeing it everywhere, because the average age of onset for Parkinson's is 65 years old. And so if we have 1.5 million people in the US with Parkinson's, that's not all from 0 to 90 as a split, right? It's all honed down into this age range from about 60 to 90 years old, where 1.5 million people have Parkinson's disease. So they're out there. And for folks that are on this call who maybe have Parkinson's, have a loved one living with Parkinson's, a neighbor, a cousin, the guy who sits next to you at Elks Club who shakes when he goes to reach for his drink, everybody has a contact. Everybody has this mental connection to Parkinson's disease. And most people's connection isn't exactly the best. I mean, for folks out there who don't have Parkinson's and don't have an association, think about what you think of Parkinson's. And it's not exactly somebody who's out there running marathons, right? But that's why I love the opportunity to meet. That's why I love teaching on this. I love talking about this and educating, because there's a ton of disease out there. And most folks with Parkinson's are either not being treated the way we do in 2023, or they're being grossly undertreated, and they're sitting back there saying, this is as good as it's going to get. Good enough is well enough. I'm 70 years old with Parkinson's. I shouldn't be going out there and enjoying life with my friends. And the honest truth is that's absolutely not true. And in fact, that's the message of hope that's come into what we do. That's the message of hope that drives us every day in clinic. And it's just this idea that Parkinson's disease as a condition is very different in how we think about it, how we approach it, how we address issues today, even than it was 10 years ago. At the bottom line, look, Steve, don't overthink this. In the world of Parkinson's, we are just dealing with a chemical deficiency, right? Parkinson's is just a deficiency of dopamine. That's it. And we take MRIs of the brain on our patients all the time. That's part of our normal workup, is to get a structural picture of the brain. And with Parkinson's disease, that should be relatively normal, because Parkinson's is not a structural problem like a stroke or a tumor or something where it's there and we can't do anything about it. Parkinson's is just a chemical problem. I tell patients every day they're a truck driving down the highway with an empty tank of gas, and when the tank runs out, of course they have symptoms. I mean, Parkinson's means that the brain has stopped making a hormone called dopamine. And so our job is simply to give dopamine back in a smooth, predictable, and consistent way, and people do better. And that's the gap there. Because if you look at the landscape of the world of Parkinson's, only about 25% of patients will actually see a specialist. So most people receive care from well-meaning internist or general neurologist who maybe see Parkinson's 3 times a week, right? And the problem is with that, we see this landscape where the vast majority of patients with Parkinson's have only tried one medicine, usually a medicine called classic carbidopa-levodopa that dates back to 1972, back when Nixon was a national hero before Watergate, so not yesterday, right? And they've tried this one medicine. They're out there doing the best they can. They're still having symptoms. They're backing away from life. It breaks our heart. And they say, this is the best it can get.
Yep.
Well, it's not, I promise.
No, that was my mom's case, is that she talked to a doctor decades ago. And as you shared, the treatment has progressed, and folks need to chat with some specialists. So this is great. I want to remind our audience, because if you're in the audience and you've got a question related to Parkinson's movement disorder and or anything in general, just throw it into chat and Q&A. Dr. Drew is very well versed in a lot of topics, so it could be.
I can help fix your car. Just throw it up there. We can try anything.
So I love it when you're able to respond to anybody in the audience, because it's like we know that we're solving somebody's problem or giving them some additional feedback. So like a couple of things, but well, the first thing, something that always sticks in my mind, and I know I'm not going to quote you correctly, but I know it's kind of tongue in cheek, but a lot of times you'll be on these discussions and you'll say something like, in 5 years, I think that, we're going to be able to treat everybody with Parkinson's. And I'm going to have to start working as a back surgeon or something like that.
I want to go work at the Home Depot. I think that would be a great backup plan. You get a great discount. You get to go tell people how to build stuff. You get to wear a cool orange vest. Like I would totally take a backup plan as being the guy at Home Depot. If we get this thing sorted out and solved. And I think so. I think 5 to 6 years is a good window.
But see, like that, I love hearing stuff like that from a medical professional who's seeing patients every day, because folks, Alzheimer's, we can't say the same thing for that. And there's a lot of, cancer, things of that nature. But to have somebody in the middle of this saying that if we can get the word out and if we can get people treated properly, that this is something that we can kind of put on the back burner. I think. Oh,
Steve, don't forget, as of today, not only is the life expectancy with and without Parkinson's exactly the same. It's exactly the same. So it always drives me nuts when we see an obituary that says somebody died of Parkinson's. They didn't. Parkinson's is not a terminal illness. In fact, I had a sweet lady yesterday tell me that life is a terminal illness. It was hilarious. But,
well, it is. All of our lives will end. Yeah.
But it's not Parkinson's. And the other thing is, as of today, we have 24 medications that we use to treat Parkinson's, 5 pieces of technology, most of which didn't exist 7 years ago. So the tools we have to bring to bear to fix a chemical problem are innumerable compared to where they were even 15 years ago. And so that's the urgency to get people excited, to get people engaged, and also to get people ticked off about what they're having to let up on. Because Steve, I tell you, I see a lot of patients every week with Parkinson's disease. I think between myself and my fantastic PA, Kyla, we maybe see 100 to 120 patients with Parkinson's every week, just my clinic. No. And at Inova, we have now 6 movement docs that all we do is see movement disorders and Parkinson's, right? Mm-hmm. But I can tell you the people I see tend to fit in a bit of a spectrum, okay? At one end of the spectrum is the person who wants to be the good patient, right? Coming to clinic is an ordeal. It's a big thing. For some people, it's fun because you get to, your kids come and pick you up. You get to get dressed up. You at your best. You go to clinic. You get lunch. It's a day, right? But that patient who comes in saying, I'm doing great, she's dressed to the nines, you can smell her beautiful perfume wafting down the hallway, she gives you a big wet kiss when you walk in. I promise you, she's doing great on that day, but she's still backing away from the things she loves. And at the other end of the spectrum is the person who's the opposite, who comes in with 3 pages of single-spaced problems where everything's going on, right? And people tend to fall somewhere in that spectrum. Mm-hmm. But the commonality that I see every day in clinic is that no matter where you are, people tend to be stepping back from the things that they love, the things that bring them joy. And they're doing it in this kind of silent, not complacent, but just kind of like, yeah, why would I be able to go do that? I'm 70 with Parkinson's, right? But it's a change that needs to happen. Because we all need to stop blaming the limitations and realize that you're saying no to things and stop blaming it all on Parkinson's disease.
Mhm.
Because if you say, you call your daughter and you say, I can't come to meet the family Saturday morning because my Parkinson's is acting up. Or you got a Zumba class you go to and you're like, you call your friend and you say, I can't come because my Parkinson's is acting up. You know what everybody does? They all say pity party. They say, it's Parkinson's. It sucks. Good luck, right? But in reality, that moment that a patient is saying no, that moment when someone feels like they can't do something because their symptoms are coming out, if this is just a chemical deficiency, then that moment just represents a moment in time where we are not giving the brain the dopamine it needs. Thus, we're letting you down and the symptoms are coming out. So we coach people all the time to blame those moments when they say no, blame those moments when they feel like they can't, blame it on their medication.
And
Because
so,
if you tell your friends my medicine's not working, so I can't go to Zumba, the friends are going to be like, medicate it better, right? There's an urgency, there's a call to action. Or if you blame things on Parkinson's, people just say good luck.
so the great scenario that you brought up there. So the woman who can't go to Zumba and she says, and let's say she's open-minded enough and she's not blaming it on Parkinson's, is like, oops, my medications are not going. Is the goal to journal that in a journal, like, okay, 10 a.m. on Monday, this is how I felt? Or and another question is there technology out there now that can sense this somehow, where I love the medical applications of these
wearables.
devices.
Yeah, it starts even easier than that. I would love to say that we can get a smartwatch on everybody that will tell us the oscillations in their motor function and where we need to address things medically. But we're not there yet. I wish. But there's 1,000 companies in the US trying to do that, because it's actually pretty hard. You have to have data and make it digestible and easy to lead to an actionable item. And each one of those is a huge step.
Yeah.
No, start easy. Write down the things that you said no to, write down the things that are bugging you, and make that be the conversation you have with your doctor. Go into the doctor's appointment and resist the urge to say, I'm doing great. If you are, sure, but say, I'm doing fine, but here's the things that I feel like I can't do, and I want to plan to try to do them. Because in the world of Parkinson's, we have 8 once daily medicines to try to stabilize dopamine once a day. We have longer, smoother versions of carbidopa, levodopa. And we also have 3 medicines that are called as needed therapies, where you as the patient or the care partner can choose to use it to fill in a pothole when it occurs. So you feel like you're going to go to exercise and your tremor's coming out and your walking's changing. You use one of those as needed medicines, and in 10 minutes, you go from being off to on and you get back to exercise.
Wow, this is great. And I don't know if I picked up on that treatment in some of our previous discussions. Well, as we expected, we've got some questions that are coming in. Marilyn says, what causes the sleep disturbances with Parkinson's? Is it the disease or the dopamine medication?
Great question. Marilyn, you get 15 bonus points for having the first fantastic question for the day. A lot of things. So sleep is something that is affected in many people, especially as we get over the age of about 65. The sleep cycle changes, it becomes more shallow. That time you spend in REM sleep, which is the restorative dreaming sleep, becomes shorter. Sleep changes. The challenge is that Parkinson's also affects sleep too. So we need to do 2 things for sleep. Number 1, we have to treat the sleep issue as a sleep problem and make sure that when you're going to bed, you're not having any screens on, because remember, blue light from TVs or your iPad or your phone, blue light tells the brain to wake up. So get the screens out of the bed scenario. And also have a good bedtime routine. So we don't want a lot of heavy meals before bedtime, especially sugar. We want to get you to kind of bring the airplane in for a landing instead of just saying, oh, now it's time to switch the light off, right? And if the sleep is still an issue with that, we might want to investigate whether something else could be going on, such as sleep apnea or fragmented sleep, which would involve talking to your doctor. But that being said, there are sleep issues that are specific to Parkinson's. So if you ever talk in your sleep or act out your dreams, that's something called a REM behavioral disorder, which is a condition that goes along with most people with Parkinson's. If that's happening, we need to treat it. And then the biggest one, what I tell folks, is to play the game with your Parkinson's, where you count out the interval of your medicines during the day. Because you have Parkinson's disease overnight, just like you have it during the day. And one of the biggest misnomers we hear is that, oh, you don't have to treat Parkinson's at night because you're sleeping. That's nonsense. If you're taking classic Cinemet, carbidopa, levodopa every 5 hours, count it. And if your last dose of medicine is at like 8, 9 o'clock, count that interval forward. So 8 plus 5, 9, 10, 11, 12, 1. If you start waking up around 1 a.m. and can't get back to sleep, the sleep fragmentation might be a product of us not treating the Parkinson's overnight. Then we treat it overnight, we come up with a plan, and people tend to sleep better, and sleeping better makes everything better, I promise.
Earlier, that's great. And earlier in your discussion, you mentioned people coming to clinic. And are you referring to that as just coming to an appointment, or is there sort of like a rehab style, like the way that you said it, it makes me sort of feel like it might be like a rehab style treatment program for people with Parkinson's?
Yeah, so it starts with letting us be the captain of the ship. So if you have Parkinson's or know someone with Parkinson's, they need to see a movement disorder specialist. If you go to your internist and they say you have a heart problem, you are obviously going to go to a cardiologist, right? If you go to your general neurologist and they say you have Parkinson's, you should come see a Parkinson's specialist, because with specialty care, we can keep people running for 15 or 20 years before things get a little different. And if it starts at 65, come see us, that means you're going to be okay, right? So it starts with us. And what we do is then integrate all of those other ancillary resources like you described, including PT, OT, speech therapy. Our center alone offers 70 to 80 programs every month for our patients for free, most of them online, a lot in person. We try to do it all because we want to surround you with support on all the ways that we know work, so that we can be your partner on that journey as you go through life. Because, yeah, you got it. Okay. Now we just need to treat it and address it the best we can, because you're going to live. Your life expectancy is the same. We got to figure out what brings you joy and get you back out there doing it, because that's the whole point of everything that we're supposed to do.
And this question that just came in relates to that. And they say Parkinson's is a chemical deficiency of dopamine. So do other treating healthcare providers know this? And how do you find the best care? And I guess, like,
they're supposed to know it.
Right.
It was on their boards. It's like third week of med school was that Parkinson's equals dopamine deficiency.
But are you still finding that, like, somebody went to their internist and it's sort of like, well, they didn't tell me that there was anything.
Yeah, we get people who are misdiagnosed all the time. So people will be told they have essential tremor and it's actually Parkinson's. They're told they have Parkinson's, it's actually something else. In fact, there's data that once you get to the level of a movement disorder specialist, we probably count about 30 to 40% of our patients as misdiagnosed in some way. So it's all about making sure we're treating the right thing, that we've named the absolute gorilla in the room, and that then we have the best plan. Because that's the biggest gap. And that's where people fall to the wayside, is that we really have had this unbelievable renaissance of medications, therapies, and tools over the last probably 7 years that have really, on a fundamental level, changed the quality of life of what we can offer patients in a great way. In fact, you come hang out in our clinic, a good portion of people, you wouldn't even know they had Parkinson's. They would pass what I jokingly call the IHOP test, where if we were sitting there eating pancakes, I wouldn't be like, oh, this person has Parkinson's. But the gap is huge between the people who use newer therapies and people who haven't, right? Again, if 90% of people have only tried or have only used classic carbidopa, levodopa, which turned 50 last year, then that means that the potential for improvement, the opportunities to help things, that they haven't even begun to be touched. But that's the challenge, and you hinted at it. The knowledge out there about how to do this is very, very low. And it's low because the old medicine works. It's good enough. Docs are busy. They're all overworked and understaffed. And in the United States today, the average neurologic visit is only 7 minutes long. So in 7 minutes, how do you spend the time and energy really diving into better treatments? You don't. You stick with what's comfortable, what's always worked. and patients get only so much better. And then the doctors go, well, this is the best we can do. And then the patients go, well, this is the best we can do. And then they stop going to Zumba, they stop going to dinner, they stop doing the things they love. And it breaks my heart.
Man. Okay, now you've talked a lot about Lillian, about medication, but Lilling says, what is the best and reliable medication for Parkinson's disease? And I know there's like a dozen medications.
Well, 24. 24.
2 dozen.
That's crazy. Okay. Yeah. It's hard, Lillian. I would love to say use X, but it's not just about using X. It's about finding the right combination for each person. We half joke in our world that if you meet 10 people with Parkinson's, you've met 10 people with Parkinson's. Every person's journey is completely different. Everybody's response to medicine, progression, symptoms, you name it, we're all as different as white and wheat bread because we're all individuals, right? So there is no good algorithm to say, do it, right? There's no manual that for you says, oh, hi, Jane. Oh, got a visitor. Hi, world. Yeah, there's no manual that says, okay, this is exactly what this person needs. We have to use the medicines that we have, the tools that we have to find the best combination for each person, which takes time, takes communicating, and takes follow-up. But we also have to have the courage that if something's not working, to keep trying other things. And so they're all great medicines, but it's hard to say what the best path is because everybody's path is just so different.
Yeah, so I think, Lillian, it sounds to me like when you've got a guide like Dr. Falconer and his team, they can modify that cocktail or the different options based on the feedback that you're giving, you're providing.
It's a process.
Okay, so now you had mentioned that your center has a bunch of free resources, and Sonia dropped in the website there for those. But Lisa asks, do you do virtual visits?
Yeah, telehealth is huge. Please take advantage of telehealth. We're still fighting on a national level for us to continue to be able to do telehealth. Look, telehealth is a lifeline for our patients. For our sickest and most vulnerable who can't travel, that's how they contact healthcare. But even beyond the folks who are really needy for it, think about the convenience of how wonderful it is. Like I see patients in Roanoke. That's like, we'll just say 15 million hours from Northern Virginia. We log in and do it through telehealth, and that's all we need to do. Or patients who are at work, I'll log in and they'll close their door. They're at their desk. They have a telehealth visit and they go back to work. It has made our lives so much more accessible to what we do. It's wonderful. The challenge is, and if anybody wants to call their state senator or representative and yell at them about this, we are bounded by our state of licensure in which we can do telehealth. It's stupid. I get it. I understand why, because they want us to pay our dues and get licensed in every state, because each licensure is like $10,000. But we can't practice telemedicine if you are outside of our state where we're licensed. So Inova is in Virginia. If you're 5 minutes that way in Washington, D.C., we can't do telehealth. If you're 15 minutes that way in Maryland, we can't do telehealth. 15 million hours that way in Roanoke, we can do telehealth. So it's a wonderful tool, but it's bound to the state in which the doctor is in for now.
Now, our audience has expanded since we've been doing these discussions, and it just blows my mind where, people jump on these calls from California. It's a great thing. Is there sort of like an academy of physicians like yours, or do you have a little pack of sidekicks that are all around that if somebody called and they were in Delaware, you would be able to help them?
Oh yeah, we know everybody. It's a small community of specialists. There's a good specialist tracker. It's called Find a Movement Disorder Specialist. Let's see, I'm going to put it in the chat.
Oh, great.
It's through the Parkinson's Foundation has one. The Movement Disorder Society has one. Here, I'm going to put the movement disorder specialist finder in.
Okay. And while you're doing that, Barbara has a question, and she says, how does the treatment of dopamine deficiency help with the soft voice symptom of people who have Parkinson's disease? And I've noticed this as well.
Yeah, great question. Remember, soft voice swallowing issues, those are all muscle problems as much as they are a Parkinson's problem. So your voice is a muscle. Your diaphragm pushes air through the lungs that goes across vocal cords to project. And with Parkinson's, all the strength of those muscles starts to wane. And so it's really important with soft voice that you are engaged with speech therapy and also vocal exercises. It's a muscle. If you experience weakness, I'm sorry to tell you, the only way to fix weakness is to build strength, right? There's no pill for I'm weak. There's no pill for my walking is off. You have to build balance. Same thing with voice. If your voice is weak, it's a muscle. We have to build strength. And we build strength through using targeted speech therapy and then following up on it with exercise and maintenance. I have people all the time who come in and say, oh yeah, my voice is quiet. And I ask, well, when did you do speech therapy? And they said, oh yeah, I did it 2 years ago. And my joke is always, that's like saying I went to the gym 2 years ago. It doesn't matter for much for now. So you got to maintain it and you have to build strength.
All right. No, that's great. Let's see. Leslie says, are there other illnesses with similar symptoms that require different or additional treatment? So
similar symptoms. So the answer is always yes. There are many different conditions that exist. It's about figuring out first what it is you got and then pair that with treatment. So essential tremor, for instance, a completely different condition.
What my mom had.
Mm-hmm.
My mom didn't have Parkinson's, but her hands were shaky. Yeah.
Yep. We have treatments for that. So it's about coming in to figure out what the options are and then picking the best one to try for you.
This is a great question from Sylvia. How late in the progression of the disease is too late to halt the level of the disability?
I would say never. There's always things we can try. There's always therapies we can aim for. But it's about having an honest conversation about where you are in things, what symptoms are present, how you respond to medicine, and what therapies there might be to try different. Because we don't want people being complacent. We don't want just an acceptance of things. We want to keep pushing and trying because every day matters.
Okay, I love our community and the questions that they ask.
Great question.
Has got a good one here. So, did you ever meet a patient with Parkinson's disease who failed all your treatments, and what did you end up doing?
Well, I let them in on the big secret that they don't have Parkinson's disease, because if you have Parkinson's, you have a deficiency of dopamine, and the medicines give dopamine back. So the oldest absolute indication of Parkinson's is you take medicine and something gets better. So and you really need to see a specialist about that, because that's a big thing to identify. But I can tell you every day we see patients, and not every day, but probably once a week or every other week, we see a new patient who didn't have Parkinson's. And the beautiful thing is, as of today, we have now 3 tests that we do objectively to give objective data as to whether you have Parkinson's or not. We have a brain scan that we do called a DAT scan that takes a picture of the dopamine system of the brain and gives us in color whether the deficiency is present or not. We have a skin biopsy that we do. It's a little punch biopsy in 3 different sites, and we stain the skin for the protein that's present in Parkinson's. And if it's present, you got it. And now we just had, fresh off the presses, we have a spinal tap that we can do and collect protein from around the spine that can identify Parkinson's. So the point being, if the medicine doesn't work, then it really brings into question whether you have Parkinson's or not. Then that would be the time to go to an objective test to give objectivity to it to define whether you have it or not.
And then using Lillian's hypothetical here, let's assume that somebody, you take these tests. What are some of the other conditions that you stumbled into that sort of manifest themselves as you thought they were Parkinson's, you tried the meds, you did the
Quack
test.
like a duck, walk like a duck, but it's a goose. Yeah, it's the great term Parkinsonism, which I kind of hate. If anyone's been told they have Parkinsonism, that's just a non-committal thing. All Parkinsonism means is ism is Latin for like. So someone's saying you have Parkinson's-like symptoms, but we're not going to call it Parkinson's disease. Don't forget, on a fundamental level, Parkinson's is a deficiency of the hormone dopamine that gives you symptoms, right? Well, in the brain, you have the factory for dopamine, which is going away. That's Parkinson's. But then the dopamine that's produced has to travel places to work, right? So there are innumerable conditions out there that impact how dopamine travels, like strokes, medication side effects, even age itself, that can give symptoms that look like Parkinson's but aren't due to not having dopamine, so not truly Parkinson's disease. There are a bunch of conditions that can mimic Parkinson's but not be related to a deficiency. And then the main thing that we see that people get tripped up on is whenever the primary issues are dexterity and walking problems, they say, oh, you sort of look like you're Parkinsonian, you sort of look like Parkinson's, so you got it, but the medicine doesn't help. And in reality, walking is a very challenging thing to do. I mean, in the world of mammals, it's pretty much us and kangaroos that only walk on two legs. And that's only the kangaroos that haven't faced Sonia, because she'll hit them with a right hook and then they're walking on all fours. That's an Australian joke because she's from Australia. But it's hard to walk on two legs. If there's muscle atrophy or weakness, if there's neuropathy, joint issues like knee and hip problems, spinal issues like stenosis or central canal issues, age-related changes in the brain, there's a whole list of things that makes walking challenging. And at some point, that can sort of look like Parkinson's disease. So the point is, anything can mimic it. But the real defining factor is, are you making enough dopamine or not? Because that's how you define Parkinson's versus something else.
Okay, great. All right. So someone says, so does a family member who has symptoms have to already have the diagnosis of Parkinson's in order to make an appointment and be seen by your center?
Nope. We diagnose people every day. So in fact, we've done a good job of working with our local general practitioners and general neurologists that we want people to come see us right out the gate. We handle the diagnosis, we handle the workup, we handle the treatment. It serves everybody better if we start it at the beginning. But remember too, by the time you have symptoms that are making people concerned about Parkinson's disease, that condition has already been present for about 10 or 15 years. It's just taken about 10 or 15 years for it to get to a point where the motor symptoms are coming out to the point that we see it, which means we really need to treat it. There are people all the time who say, let's not treat it until it gets really bad. And we hate that. That's malpractice, right? You have a deficiency. We're just going to let it go out there and let you struggle. And then you get to tell us when you're ready. Well, that's not fair. We got to treat it.
Now, on that topic, are there things, I'm sure there's been a lot of research on this in terms of studies that say, well, if you eat avocados, you've got a high incident of Parkinson's. Is there any correlation with our behavior or our diets or anything like that that has led to Parkinson's?
Yeah, no, you're okay in that. Now, I can tell you that
just a genetic.
Well, it's a combination of two things, we think. So Parkinson's, we believe, comes about because of a combination of a genetic predisposition. So you're predisposed to be at risk for it. By the way, not inheritable for the most part. So it doesn't run in families for the most part. It's something that just you're born with a risk. And then we find it pairs well with something environmental that triggers it, but not something like diet or lack of exercise. And we don't know what to do with that. That's not something that we can intervene upon. Now, I can tell you the people that do their best are the people who exercise, who have been exercising, and the people who maybe don't live on avocados, but the people who eat healthy. So pick a Mediterranean diet, a good leafy green vegetable diet, who knows? Healthy eating, healthy living, all the things your mother told you were the best do help over time.
That's great. Okay, Sylvia has a good question here. How difficult is it to treat Parkinson's if you also have been diagnosed with Alzheimer's disease? And how common is that?
That's extremely uncommon, and it would make me concerned that you don't have one or the other. Usually, if we have somebody who comes with both diagnoses, someone was just kind of, mincing details and overlooking things. People with Alzheimer's disease over time can look like they have Parkinson's because of how Alzheimer's affects the brain, but that doesn't mean you have a deficiency of dopamine, right? Parkinson's deficiency of dopamine. If you have the deficiency of dopamine, you can get dementia syndromes that are associated with Parkinson's, which is very different than Alzheimer's. And it becomes murky because on a very structural level in the brain, the proteins that are off with Alzheimer's and Parkinson's dementia all kind of overlap. it's not very clean. So we see that when folks have both diagnoses, people are just being a little overeager in their labeling. And in reality, they probably have one or the other.
Okay. Gloria and another attendee kind of have two, I think, related questions. Gloria says, can our blood work detect this disease? I'm a cancer survivor and my mom had Parkinson's for 10 years and suffered in a nursing home. I have a fear. So I think Gloria is sort of, we take a test now that shows that our body produces less dopamine and we could have a potential for Parkinson's.
Yeah, so we can. So that's the DAT scan, the brain scan, the skin biopsy are indicated for once you have symptoms, right? The test that we have that just got released, we'll see if we have availability to use it, is the spinal fluid. So we can test for proteins in the fluid around the spine that can give us evidence if you're at risk for Parkinson's. Again, it's the kind of thing where we would be very hesitant in many cases to do that because, Parkinson's is only inherited in conditions in cases, maybe 5-6% of the time, if that. So, I mean, you're running heavy odds that it's not an inherited condition. And so it would start by just having a good conversation. So come see us. We'll talk about how life's going now, and that can at least let us project out 10 or 15 years.
Got it. Barbara says, I've read that traumatic brain injuries trigger Parkinson's. Is this true? And if so, how does it work? Does TBI impact dopamine production?
It's different. So TBI, and I mean, the most famous case was Muhammad Ali. Thank you. I blanked for a second. Remember, Muhammad Ali got really bad Parkinson's. He had a very specific type of Parkinson's called Parkinson's pugilistica. Pugilistica is a fancy Latin word for boxer, because in the world of boxing, with all the repeated head injuries, people are at a much higher risk of developing Parkinson's. Now, that's not really always because of a dopamine problem. It's more because of the damage that's been done to the brain affects how the dopamine that's left can work. And so it's a bit of a different condition. So any TBI related thing tends to be different than true classic Parkinson's.
Okay. Now, Janie asked a question earlier on in the discussion, which I think you've answered a bunch of this, but I just want to read it in case you've got anything to add. And she says, are there different interventions for people with movement disorders?
Yes.
Okay.
In a huge way, yes. And that's the exciting part. Look, we have people who come to clinic. They think there's nothing we can do. They think they're either going to become Michael J. Fox, which is he's reproducible to no one because of his history. And they think they're either going to become him or the guy at church who they have to bring communion to. And they think that's where my life is going. It's all over. Forget the cruise we're going on next year. And there's nothing we can do. And then we sit them down and people leave with hope because they realize that this is in many ways a treatable problem. And that we just have to work together to find the best treatment for now to get you on that cruise that you have scheduled. And then we back that up by actually giving them medicine that works, by pairing that with the social exercise and educational support that our center gives. And we truly walk that walk with them. And all of a sudden, not only are they going on that cruise, but they're feeling great about it and scheduling their next cruise. And it starts by realizing that you can't take somebody else's experience and say, that's going to be me, or projecting it onto yourself. You are special, you are amazing. We need to figure out what your body needs to get you back doing those things you love. And I can tell you that there are options out there where people come in and I have yet to tell someone ain't nothing we can do.
And, when you go to the website for the Parkinson's Movement Disorder Center, the amount of programs, like I was just before the discussion, Sonia was telling me about the rock climbing programs, and I've been involved with some singing programs, and there's support groups and all kinds of resources out there that probably a lot of people don't know about.
Rock climbing. I mean, picture that.
Yeah.
Take whoever's out there who doesn't have Parkinson's or is not connected to it. Take what your brain pulls as this is Parkinson's to me and project that onto somebody climbing a rock wall. Or dance for PD. Dance for PD is the coolest thing I've ever seen. David Rosenthal, he's a genius. And he has awesome red shoes, so you can see how he's dancing. It's the coolest thing. Imagine that person doing pirouettes and waltzes, right? Not going to happen. But that's where we have to break what society and our preconceived notions have of Parkinson's. Because if we all think about it as the worst case that you read on the internet, you all think about Michael J. Fox or what your brain says is Parkinson's, then you just kind of give up. And it's not the case. We have patients with Parkinson's, twice a week, Sonia, who get on a rock wall and climb. And they do it beautifully. We have people every week who do our multi-step tasking. 3 times a week we do rock climbing. Thanks, Sonia. We have a dance class at the Kennedy Center on Sundays that's free, that's filled with people dancing with Parkinson's. And they are happy, they're loving it, and they're doing it. Because, Steve, guess what? So if this is a chemical problem, right, just a deficiency of dopamine, well, do you know what the 2 natural ways to get your brain to produce extra dopamine are?
Exercise?
Exercise is big number 1. Everyone out there needs to move. They need to exercise every single day because the runner's high, for instance, that's an extra surge of dopamine, makes you feel good. When you exercise and you're like tired and then afterwards you feel better, it's extra dopamine. So you all need to exercise to tell your brain to make more dopamine. And do you know what the second thing is that makes?
Well, I know it's not eating avocados, so
they're good though. No, it's happiness, joy, right? If whoever's out there has grandkids, when your grandkids hug you, how do you feel? Right? Yeah. $1 million. When my 5-year-old takes my face in her little hands and tells me that I'm her heart, I feel like $1 million because my brain is giving me a surge of dopamine.
Yep.
So we have to get everybody out there doing the things they love, doing the things that bring them joy, because that makes you make more dopamine too and helps your Parkinson's. And so consider all that happy stuff as also a medical imperative as well as just the right thing to do.
I love it. Okay, so back to the questions here. Is the dopamine level a blood test? And once diagnosed on the medication, is the dopamine levels watched throughout your life?
There's no blood test. I wish.
But it's more that the patient is reporting how they feel, and that's how you monitor the levels. Yep. Okay.
It's how good are you? When your tank is full, you're better, or whatever that is for you, better. We want to keep you there all the time.
And Barbara has a good question. Can you address increased feelings of anxiety? And I can imagine that there can be clinical anxiety associated with this. But just the anxiety that, geez, I don't like how, I'm my movements in front of people and trying to hide that.
All that. Yeah, look, this is a dopamine problem. On a chemical level, dopamine makes you feel happy. To be low or fluctuating in dopamine causes depression and anxiety. And then also just the normal social response, that kind of reactive depression. You're nervous about being seen and judged. You're depressed because your movement is different and it's not going, and it's not changing. All these things are real, and we got to talk about them. I don't want people being the good patient and saying everything's fine. If it's bothering you, talk about it, because we need to treat it. There's very effective treatments for anxiety and depression as well.
Okay, looks like we're about 10 minutes till we'll be wrapping up here. But my friend Bonnie Elliott, hi Bonnie. How does Agent Orange trigger PD, and are there other chemical exposures that trigger PD in addition? I've never heard of that.
Yeah, so even the government's admitted, the VA, that people who are exposed to Agent Orange have a much higher risk of developing Parkinson's. Again, remember, genetic predisposition paired with chemical exposure. Agent Orange is one of those chemicals. And somebody wrote about Camp Lejeune. Yeah, there is a defined connection between growing up and drinking the well water at Camp Lejeune with developing Parkinson's disease. In fact, there's a huge section of California, that kind of breadbasket of the West, where for 200 years, there's been pesticides going down into the groundwater, where if you grew up there, your chance of getting Parkinson's over life is about 10% higher than the rest of the population. So we know that chemicals have a connection, but it's really hard to do, because how do you avoid that in life? And you can't.
Okay. And Paul, I'm looking for your question and I don't see it. If you don't mind stating it again, or raise your hand and we can bring you on mic to ask it. And then Judith says, how much is known about environmental factors? For example, there seems to be a correlation between having lived near Camp Lejeune in North Carolina from 1953 onward. I was born in a military hospital in 43, so I'm not part of the specific statistics, but the coincidence makes me curious. I was diagnosed in 2019.
Yeah, if you didn't live there, I don't think there's a federal fund for people who grew up at Camp Lejeune. So go look it up on the internet. There's a settlement that people who grew up in Camp Lejeune can attend through the VA, and also not VA if you have Parkinson's.
Great. For anybody out there who had exposure to Agent Orange, Bonnie also mentions that the Veterans Aid and Attendance Program almost automatically always approves people who have been exposed. And if you're not familiar with that program, it's a program that will help pay for care if you're a veteran. Thanks for sharing that, Bonnie. Let's see, we have a dear family member who recently passed away at age 71. She had Parkinson's many years. She had tried to manage unsuccessfully chronic long-term constipation. She was told many people with Parkinson's have or have had long-term chronic constipation. What are your thoughts on this?
Yep. So according to the Michael J. Fox Foundation, 90% of patients with Parkinson's have constipation. And I always joke that the other 10% are just shy about it, because everybody has constipation with Parkinson's. Parkinson's is a slowing condition where things slow down. If you think about it as it slows down movement, your gut is also moving and it gets slowed down too. So constipation is part of it. We got to get you going to the bathroom every day or every other day, because if not, the medicines aren't going to work as well because they're getting caught in the train of things not moving. Sonia just put up on the chat a good recipe and some recommendations that we give for constipation. But Guess what? Outside of all that, drink more water and exercise. If you drink more water, it helps with constipation. If you exercise, things move better.
Okay. Paul's question is, and it's a good one, how do you determine if your neurologist is an expert in Parkinson's and movement disorder?
Go to their website and look and see if they did specialty training in movement disorders. So you can actually go to the website that Sonia had put on there, where you can search for a movement specialist and see who's in your area. That's the easiest way.
Great. Janie says, what would you discuss the diagnosis and treatment of essential tremors?
Yes. So essential tremor is very different than Parkinson's. Essential tremor deals with tremor with activity instead of tremor at rest. It is treatable. We have 3 or 4 good medicines right now to treat essential tremor with. We have deep brain stimulation and focused ultrasound, which make it gone for most people, which is beautiful. And we have 2 new medicines that are coming out either later this year or early next year that specifically target essential tremor and should be game changers for us.
Great. Okay. We're getting close to the top of the hour. Got a couple of good questions here. The first is, how much do Parkinson's treatments and medication cost each year?
Yeah, no way to tell. It is a game. I don't know if you all are into the game yet, but the healthcare system is not built to help you or me, and it's not built to let me be the one who makes decisions. There is a purposeful gap between the physician and what it costs you when you pick up your medicine. I have no way to tell. And the problem is there's no such thing as drug cost. If I go to 4 different pharmacies locally with cash, I'm going to get a different price for something than if I have GoodRx, than if I have a coupon, than if I go to mail order, wherever that may be. It's all different pricing. And then if I start to use insurance, it's going to change at every location. And it's also going to change where you are in your year. Have you met your deductible yet? Are you in the donut hole, which sounds delicious, but it's not, it's terrible? And are you in catastrophic, which sounds terrible, but is actually awesome? So it's a game. There's no way to tell. So what you need to do is realize that medicine cost is more of a copay problem and a coverage problem than really a cost problem. pick a path that makes the most sense, pick a medicine that seems to fit a need in your life. We send in the prescription and you call and ask for the copay. We can't even call and ask for the copay. It's got to be you.
Wow.
And if it's cheap, you won the lottery, get it, let's do it. If it's expensive, realize that it's a copay problem. Don't pay it. Don't pay the expensive medicine. Call and let your doctor know, because there are programs that we use. There are things we do. There are tricks to play the game to fight the insurance company to get them to cover it, to make it cheap.
Wow. Dr. Falconer, I would like to have you back on to have a discussion about the game. And
we'd have to drink while we were talking about that.
Yeah, no, it'd be crazy. Well, or we could do something else, because Ruth has a question. Does cannabis help with dopamine?
Sure. Yeah, we've been treating Parkinson's with cannabis since the 1800s. How we implement that, how we utilize that clinically is still a very much heavy question because of the state federal requirements on down. But bring it up with your doc. We talk about that all the time. Great.
Man, look at this. We got through that pile of questions. We had a great discussion. It's raining outside, but we're getting compliments left and right for the discussion today. So I feel like we solved some people's problems and we opened their eyes. But most importantly, we got a group of people who now, when you're at a barbecue or you're at a family gathering, that you just tell your friends and loved ones to talk to a neurologist with specialty in Parkinson's and movement disorder. And hope. Look, the worst thing that I've seen happen, and this is our fault as a medical community, is we have stolen from patients that drive for better and hope. And it comes from doctors being complacent and just saying, good enough. You all got to get out there and get mad about it. You got to realize that life is beautiful. And if we're not doing the best we can today, then it starts with you being an advocate for yourself to stand up and say, I want to try something different. I want to go back to doing this, and realizing that that is not only a possibility, it can be a reality. I love it. Thanks so much. And I know that you're probably ready to see another patient, but folks, back to it. Have a great weekend, and we'll see you at the next one, Dr. Falconer. Thank you, Steve. Thank you, everybody.